On behalf of Hetero Healthcare, a very good afternoon and a warm welcome to the esteemed speakers of today's webinar on the topic Antivirals in COVID-19, Hit Hard, Hit Early. And also a warm welcome to all the delegates who have joined us today. I take this opportunity to introduce Dr. Sandeepa HS, who is an eminent MDDM interventional pulmonologist associated with BGS Green Angels Global Hospital, or an esteemed hospital in Bangalore, and who is also a member of Institute of Pulmonary Medicine Research and Development. Dr. Sandeepa has treated several COVID patients right from the start and continues to do that now also. Dr. Sandeepa, over to you to start the session. Thank you.
Yeah, thank you, Sheetal, for the kind introduction. And I think it is. I would like to thank Hetero for organizing this, continued medical education program. And they have been continuing it, carrying it out throughout this COVID-19 pandemic. I think this is again another add-on to this particular series of CMEs. So it was supposed to be attended by one of my fellow colleague as well, Dr. Chetan. Unfortunately, he had an issue with his spine and he is not able to join us today. So I apologize on his behalf, and I would like to welcome my good old friend, Dr. Kapil, who is an infectious disease expert, also a chest physician. He has been actively treating cases of COVID in Mumbai. And welcome, Kapil. So without wasting much time, I think we are already running late by around 10 minutes. We'll start with the presentation. So as the title aptly says, so antivirals in COVID hit hard and hit early. I think this is something which is very, very important. See, that definitely, as you know, just a minute. As you all know that COVID-19 is a viral disease, and fortunately, for the benefit of the treating physicians as well as the patients, there are good antivirals which are available. If they are used at the right time in the right patient, then it can save them from losing their lives as well as save them from developing post-COVID complications. Okay. So I'll be taking for the next maybe 20 to 30 minutes, I'll be taking you through the antivirals, what are all available in COVID-19 with a special focus on the oral antivirals, especially for mild to moderate cases. So for the next half an hour, I'll be discussing on the COVID-19 current scenario, COVID positive and asymptomatic patients, how do we go about with them? Benefits of starting early favipiravir, that is the oral antiviral within 72 hours. Importance of treating family members and post-COVID complications in COVID-19 recovered patients not treated with antiviral. This is only, I'll just enumerate them. So coming to the current situation of COVID-19 pandemic in India, the novel coronavirus disease, that is COVID-19, has already affected over 6.9 million people, claiming more than 4 lakh lives in over 200 nations all over the world. We all know that. As on December 1st, 2020, 94.6 lakh cases reported in India, out of which 1,37,659 deaths and around 88,89,000 88,89,585 cases have recovered. This is 1 crore rather than close to 1 crore cases we have reported in our country. ICMR mentioned that 80% of our cases in India are either asymptomatic or mild, 15% are moderate, and 5% are critical. You might have encountered this during your routine clinical practice as well. So what are the challenges in COVID-19 pandemic era? We all know the number of COVID-19 positive cases has been ever rising since the first case. Fortunately or unfortunately, it was first case of India was reported in our state, that is Karnataka. That was in Gulbarga, I think. One of the person who had returned from Dubai was the first case to be reported in our country. So rising number of COVID. Since then, the number of cases has been increasing since the recent, maybe around 15 to 20 days ago, where there has been a sharp dip in the incidence of cases throughout our country. But unfortunately, Delhi and Ahmedabad had Rajasthan, those eastern part of our country, saw a sharp shoot up in the number of cases. That has made all of us much more, vigilant. And we are expecting another surge of cases in the coming days as well. I think this particular thing, previously, I think we were not very much well versed with the management part of the COVID-19 infection. So now we know what to use, when to use, how to use. And now at this juncture, I think it is more important for us as doctors to identify the cases early, to treat them with appropriate antivirals and additional supportive therapy, so that we can save many more lives as we have done in the recent past. Rising number of COVID-19 positive cases is a challenge. Limited healthcare infrastructure, definitely. I think everybody will agree with this particular statement. The healthcare infrastructure in our country is very limited. We will not be able to accommodate everybody in the hospital the way we did it in the past, which will give rise to unnecessary shortage of beds and unnecessary chaos. Many patients who deserve admission will not be able to get the bed, whereas in people who are more or less stable, in mild cases, they are occupying the beds. So limited healthcare infrastructure is another challenge for our country in COVID-19 pandemic era. Overburden on healthcare system, I think Kapil will agree, I think, with this statement, because from past 6 months, I think most of the doctors in our country have been overburdened with the cases. Cost of the COVID-19 treatment, government should the healthcare expenditure has shot up like anything. I think it has gone more than 5 to 10 times of the reserved budget, whatever was there. So that is why there has been additional funding of the, this particular COVID-19 pandemic treatment, as well as for the other health infrastructure. The cost involved in COVID-19 treatment is again a big challenge. Increased incidence of post-COVID-19 complications, even in asymptomatic patients. This is something which we have to see as a challenge in our country. So coming to a brief overview on COVID-19, most of you must be aware after attending so many webinars, but still I would like to brush through them in a rapid way. The most common symptoms of COVID-19 are fever with chills, okay, or fever alone, usually a high grade fever, myalgia, cough, rhinitis, okay. Some people will eventually progress into shortness of breath or difficulty in breathing. There are atypical presentations of COVID-19 with vomiting and diarrhea as well. The most important characteristic feature of COVID-19 infection, which we have understood very well and which might be a clincher of the diagnosis, is a loss of taste and smell. That is anosmia and dysgeusia. Okay, so these are the ones which are the classical symptoms of COVID-19. So till the pandemic gets over, I think for the next another 3 to 4 months, at least 6 months, till mid 2021, I think whoever visits to us with fever, myalgia, or any upper respiratory tract kind of any symptom, it is important for all of us to suspect COVID-19 and think that the patient is having COVID-19 infection and start them on empirical treatment till we get a further confirmation of the diagnosis. So to repeat the symptoms again, most importantly, fever, chills, myalgia, and generalized weakness. Okay, I think most of the people are from Bangalore. I think they will understand Kannada. Sustu is a very, very classical symptom of COVID-19. Along with this, if the disease is progressing, then there will be rhinitis, blocked nose, running nose, sneezing, and all those things. Along with that, cough, shortness of breath, and difficulty in breathing can be seen. Most importantly, you have to remember new loss of taste or smell. This is very, very classical. And these are additional atypical features which include vomiting and diarrhea. So coming to the classification of COVID-19 patients as per Ministry of Health and Family Welfare, they are classified broadly into mild, moderate, and severe category. Coming to the symptoms, see, mild, moderate, severe category, there might be overlapping of the symptoms. So what is important for all of us, for treating physicians, is oxygen saturation. That is what I would like to highlight. See, if the oxygen saturation is normal and the patient is symptomatic, you classify them as mild. If the oxygen saturation is somewhere between above 90 to 94, you classify them as moderate. And anybody who is having oxygen saturation of less than 90%, you classify them as severe. This is a simple classification based upon pulse oximetry. I think most of you will be having pulse oximetry at your clinic level. So the moment the patient tells you about these symptoms, what you have to do is, see, most of us will be wearing PPE, going, hearing with stethoscope, and all those things are not really possible and not really recommended also, because there are no classical features suggestive of COVID-19 infection on auscultation and palpation. The clincher, the most important thing what we have to do and what we can do easily in our clinic is just to check the pulse oximeter, well, that is oxygen saturation. If the oxygen saturation is normal and the patient is having symptoms, then you classify them as mild COVID. If the patient is having a saturation of 90 to 94 and the symptoms, you classify them as moderate COVID. And anybody with a saturation of less than 90%, you classify them as severe. This is a simple classification based upon pulse oximetry, which can be done at everybody's clinic. So this is what we have to remember. So coming to the differentiation between acute lung injury, H1N1, SARI, and COVID-19. See, for me, if you ask me, till now, I think I recently had a viral infection. I think now we are seeing some cases of non-COVID infection also, non-COVID viral infection. That becomes very, very important. How do we differentiate between these two? See, non-COVID viral infections are not very severe. They usually start with rhinitis and maybe they might progress to pharyngitis. Fever might be present on one day and eventually it will go off. Myalgia also, it will start recovering. See, usually the disease will not be progressively increasing, or the disease will not be in a worsening mode beyond 3 to 4 days. This is what I can tell. Okay, but when it comes to COVID-19, fever, myalgia, cough, lack of energy, sore throat, breathlessness, anosmia, diarrhea, all these things are known to be present and they are known to be progressive over these 3 to 4 days. If it is a non-COVID simple viral infection, maybe rhinovirus or adenovirus or something like that, then the symptoms, the severity of the symptoms will start on the day 1, peak on day 2 or day 3, and from day 3 onwards, it will start usually dropping down. But that is not the case in COVID-19. COVID-19 usually is a progressive disease because as you all know, it is a 2-week disease. Just to summarize how to differentiate between the symptoms of H1N1 and COVID-19. So fever is present both in H1N1 and COVID-19. Myalgia also present in both H1N1 and COVID-19. Cough can be present in H1N1 and COVID-19. Lack of energy can be present in both of them, but I would like to say lack of energy is something which is very, 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 very important in COVID-19, because most of the people will have that complaint. I mean, sustu. That is something which they keep on constantly complaining. This is not which we have commonly seen in H1N1. See, we have seen. I was a PG in 2009, 2010, 2008, 2009. During that time, we had a H1N1 pandemic in a similar way. At that time, this sustu was not a very classical symptom. Okay, generalized weakness or lack of energy was not a classical symptom. But in COVID-19, it is very, very classical symptom. Sore throat can be present in H1N1 as well as COVID-19. Breathlessness, yes, H1N1 can also progress from mild, moderate to severe. The H1N1 can also give rise to ARDS and respiratory failure. H1N1 can also give rise to acute lung injury kind of a picture. Whereas in COVID-19 also, this can progress from mild, moderate to severe. Most importantly, anosmia is very classically present in COVID-19, and diarrhea also, that is atypical presentation of diarrhea, is also seen in COVID-19. So these are the two important clinchers which we have to include during our history taking before arriving onto a particular diagnosis or before starting somebody on an empirical treatment. But for all practical purposes, take it from me, it is COVID-19. Any upper respiratory tract infection, any lower respiratory tract infection is COVID-19, unless until proved otherwise. For us, it is very clear. As a pulmonologist, I see every patient coming to my OPD as a COVID-19 only with a higher suspicion index. And if I get convinced that it is not COVID-19, then only I will move on to other differential diagnosis. So you all know RT-PCR test is something which we commonly use for the diagnosis. Now rapid antigen testing is also done, but you should also know that RT-PCR is not a 100% sensitive and 100% specific test. Okay, it has got a sensitivity of somewhere close to around 70 to 75%. That means out of 100 cases of positive COVID-19 infection, RT-PCR positivity is seen only in 75% of cases. In remaining 25%, it can still come as negative. Therefore, it is very, very important for us to rely more upon clinical diagnosis rather than the laboratory diagnosis. Next commonly performed investigation is chest X-ray. Yeah, majority of the time, as ICMR has clearly said, 85% of cases are mild. So only around in mild cases, majority of the times X-ray picture will be more or less clear. In moderate to severe cases, you can see these peripheral patchy areas of ground glass opacities, okay, which are very, very classical of COVID-19 infection. Here you can see peripheral consolidation involving the upper zone as well as it is classically more of a lower zone. Here you can see a patchy involvement, a bronchopneumonia kind of a pattern with more peripheral distribution. In CT scan, we say them as a ground glassing of the, parenchyma. So that is the next commonly performed investigation. So whenever you are in doubt, see, personally speaking, it is more of a clinical diagnosis rather than a laboratory diagnosis. Other than whenever you are in dilemma, now you might ask for CT scan because the incidence of other viral illnesses is also slightly increasing. So whenever you are in a dilemma, whether it is really COVID-19 pneumonia or it could be something else, then you are free to ask for a routine CT scan, HRCT thorax, which will show classical ground glass opacities, crazy pavement, depending upon the severity. You might all be knowing Corad score. Nowadays, every radiological report, every CT scan report involves a Corad scoring. Even for pulmonary edema, even for cavitary tuberculosis, there is a Corad scoring which is being given. So we should be we should not be hesitant in asking for a CT scan whenever we are in dilemma, because that time if the CT scan turns out to be positive, or if the CT scan is showing some features of COVID-19, we will be much more sure, and the RT-PCR test report might take a slightly longer duration of time as compared to CT scans. So CT scan is the classical investigation which we can ask, most commonly performed. It will present with the patchy ground glass opacities, more involving the bases and the peripheral distribution. So to summarize, okay, what is clinically available at our what is easily available at our clinic is pulse oximeter. I would rely more upon this. I think Chetan is missed. He used to call this pulse oximeter as Brahmastra. Brahmastra against COVID-19 is pulse oximeter. So it is unfortunate that he is not there in the CME. He was supposed to join, but this is something which we have to very commonly use, and we have to judiciously use this pulse oximeter. And whenever we feel that the saturation is on a borderline, then we should not be hesitant in becoming more and more vigilant in suspecting COVID-19 infection. Chest X-ray, as I told, it is not very specific. I think now, as the days pass by, X-ray will only remain as a screening tool for maybe tuberculosis. I think majority of the times it is CT which has become a primary investigation for all of us, especially pulmonologists. We will never stop ourselves at X-ray unless until it is something which is classically which we are seeing, and something which is diagnostic on X-ray only. Whenever we are in doubt, we jump onto CT scan for further communication. I think CBC count and all those things, nucleoside, neutrophil lymphocyte ratio and all those things you might all be knowing already. CT scan, as I told, is very, very important from now. I think in the second phase, where there could be possibility of other viral infections coming in, then I think the role of CT scan is much more higher now rather than it was before. PCR testing, as you all know, now rapid antigen testing is also available. Government is doing free of cost. You can use it according to your convenience, but never ever wait or never ever withhold your treatment till you get the RT-PCR report. If you are clinically suspecting, if the patient is having clinical features, if the saturation is okay, more or less in a moderate to mild category, I think you should not be hesitant in starting them on proper anti-COVID treatment. We have got nothing to lose, because favipiravir or maybe even remdesivir in severe cases is not a bad drug. They are relatively safer drugs. They don't have much side effect. Okay, they are very well tolerated. They are easily available. So when these all factors are there, then we should not be very hesitant in using the upfront Okay, antivirals. See, till now we don't hesitate in using antibiotics, right? So any patient comes to us with a cough, fever, even if for 1 or 2 days, I think we don't hesitate to write azithromycin or maybe augmentin, amoxicillin or something, levofloxacin or something like that. So when we don't have hesitation in writing an antibiotic for a viral disease, I think there should not be any hesitation in writing an antiviral for a viral disease. So from now onwards, I think the usage of this favipiravir and oseltamivir interchangeably, maybe in H1N1 suspected cases, is more or less an empirical treatment rather than waiting for the confirmed reports. So as a pulmonologist, I would suggest you to go ahead with empirical treatment for antiviral, viral illnesses in respiratory tract rather than waiting for the confirmation of viral illnesses. Okay, important investigations, CBC. You all know lymphocyte neutrophil ratio in CBC is very important. D-dimer, again, D-dimer, higher the D-dimer, higher the chances of thrombosis. So better to put them on anticoagulation. CRP levels, again, elevated CRP level is a sign of serious infection, as you all know. And higher the CRP, and again, timing also is very important. CRP is elevated at what time of the illness, whether it is in the first week or second week. If it is in the second week, it is more of an inflammatory marker. And if it is in the first week, it is more of an infectious related marker. Ferritin levels, again, it is an acute phase reactant. Interleukin 6, LDS, they are all known to be beneficial. I will not go much into the details of them because most of you might already be knowing, because we are already 6 months into the pandemic. Okay, so these are the basic investigations which we commonly do. If you ask me, I rely more upon CBC, D-dimer and CRP. Ferritin is okay, plus minus use. Interleukin 6, we have hardly used any tocilizumab in our practice, but still it is a very well known investigation. I think Kapil can add his knowledge regarding interleukin 6 and tocilizumab in a later session. And LDH, again, it is again a marker of a lung injury. See, LDH is released by the lungs. So higher the LDH, so higher the possibility of lung injury in COVID-19 patients. So coming to the complications of COVID-19, you all know COVID-19 can end up with pneumonia, can end up with sepsis, ARDS, septic shock, cardiac failure. We have seen a lot of MIs, strokes and all those things. They are also known. Renal failure, fortunately or unfortunately, I don't know. The first case of COVID which we treated in our hospital was acute renal failure, secondary to rhabdomyolysis in a case of COVID-19. So acute renal failure also can present, COVID-19 can also present with acute renal failure. So these are all the complications which can occur due to COVID-19 infection. Now coming to the important topic of discussion, what is the role of antiviral favipiravir in the treatment of COVID-19 infection? Favipiravir is also known as Favipira or Favilavir, is an antiviral drug which was developed by Fujifilm Group of Japan. Favipiravir is an antiviral agent that selectively and potently inhibits the RNA polymerase. Favipiravir has shown activity against influenza viruses, West Nile viruses, yellow fever. It is more or less a broad spectrum antiviral. We know about broad spectrum antibiotics. Now this is something called as a broad spectrum antiviral. Both Favipiravir and remdesivir, I think I am happy to use this term. They have been shown to be effective in many of the viral illnesses, and results are clearly seen in COVID-19 infection also. It is one of the most potent broad spectrum antivirals. So there should not be any hesitation in using this favipiravir in any kind of viral infection. Now COVID-19 is there, okay, that is there, but any other viral infections can also present with upper respiratory tract infection kind of a picture. If it is not H1N1, favipiravir, it is more or less safe to use because it is shown to be effective against other viruses also. But in this particular context of COVID-19 pandemic, it is a wonderful drug which has got a broad spectrum antiviral activity and which has shown to be very, very effective and which is very, very potent in controlling the progression of COVID-19 diseases. Favipiravir has been approved for experimental use against COVID-19 by Italy, China, and India, as you all know. So mechanism of action, I will not go into detail. Basically, it is a RNA. It is a RNA polymerase inhibitor which will prevent the viral replication. Therefore, the viral load will rapidly decrease. Okay. What are the salient features of favipiravir? So I told you it is a broad spectrum antiviral. Early initiation within 72 hours helps to reduce the rapid viral progression because it is a RNA polymerase inhibitor. It brings down the viral load. Early initiation helps to overcome the disease progression, offers faster viral clearance within 4 days and symptomatic relief within 7 days, reduces chances of hospitalization and reduces overall treatment cost, limits the future complications of post-COVID-19 recovery. So these are the salient features of favipiravir. Just to highlight them, favipiravir is a broad spectrum antiviral agent. Hit it early for the best result. It brings about rapid viral clearance and symptomatic relief within 1 week. I told you COVID-19 is a 2-week disease and patients will be suffering for 2 weeks. If we initiate favipiravir early in the course of the disease, then the duration of symptoms will also come down to less than a week. Once the symptoms are better, once the patient is better, the chances of his hospitalization will also come down. Once the hospitalization comes down, the cost of treatment will also come down. And most importantly, if the disease progresses, the chances of developing complications is high. So it also brings down the chances of post-COVID complications. Now, what does the evidence say? So what are the evidences available for the usage of favipiravir in COVID-19? So this was a newspaper article published in Times of India, Mumbai, 21st November 2020. They told that COVID-19 task force recommended timely use of antiviral drug favipiravir to reduce the severity of the infection. Favipiravir is a safe and effective treatment in mild to moderate COVID-19 cases, and it may reduce the duration of clinical signs and symptoms in inpatients. So this is a newspaper article based upon the study done by few of the consultants in Mumbai. Okay, the official publication is yet to arrive. I think once it is available, it will be much more significant evidence. But as far as anecdotal experiences is concerned, so there are 2 pulmonologists or 2 infectious diseases people who are sitting here, I think, who have treated more than 1,000 to 1,500 cases of COVID-19. And it is personally our clinical experience. Few of our colleagues who had COVID-19 infection, the moment we started them on favipiravir, I think we were able to bring them down and bring them the symptomatic relief as well as prevent their hospitalization just by initiating the favipiravir early. Okay. 150 patients with mild to moderate symptoms were chosen to evaluate the efficacy and safety of favipiravir treatment versus standard supportive care alone. Within 48 hours of them testing positive for COVID-19, patients received 3,600 milligram of favipiravir on day 1, followed by 800 milligram twice daily standard dosage for 14 days, along with the standard supportive care. Randomization was stratified based on the disease severity into mild and moderate patients. So the conclusion was favipiravir seemed to be having a faster clinical cure and, more importantly, faster viral clearance than those randomized to the routine care group. In this study, it has been found that 69.8% of patients in the favipiravir treatment arm achieved clinical cure by day 4. I think that is something which is wonderful and which is very, very encouraging for all of us. So the earlier we start the treatment, the better will be the results. There should not be any hesitation in starting the antiviral on an empirical basis. Later you can stop it, no problem. If the diagnosis turns out to be something else, then you can stop the antiviral, no problem. But do not hesitate. Do not wait for the test results to come. Do not wait. Do not delay, or do not bargain. I mean, do not waste more time in identifying or proving that it is COVID-19. I would like to tell you, reiterate that any case of fever with upper respiratory tract infection is COVID-19 unless otherwise proved, at least in the present era. So there should not be any hesitation. And this study, the results of this study are very encouraging. That is, close to 70% of patients have got a clinical cure by day 4. So again, hit hard and hit early. Earlier you hit, harder you hit, the outcomes and the results are better. Coming to the dosage of favipiravir, I told you, start early, as early as within 72 hours in symptomatic COVID-19 patients. And even in asymptomatic COVID-19 patients, I would like to withdraw this statement actually. So in asymptomatic patients, I have not started anybody on favipiravir. I would wait for them to become symptomatic. And once they are symptomatic, whatever might be the symptom, maybe myalgia, headache, or maybe fever, if they are in contact with a patient who has turned out to be COVID-19 positive, the moment they develop the first symptom, whatever might be the symptom, any sign of first symptom, I would like to start them on favipiravir. Asymptomatic patients, we can still wait, because as you all know, majority of them might remain as asymptomatic and they eventually will overcome the disease. So what is the recommended dosage? On day 1, you start them with 3600 milligram. Earlier, it used to be only 200 milligram tablets which were available. The patient had to consume 9 tablets in the morning, 9 tablets in the night. That was slightly tougher on the patient part, because the pill burden was more. Along with that, they have to take other pills as well: vitamin C, vitamin D, antiplatelets, these anticoagulants, and antacids. There are so many drugs. But now, with the advent of 800 milligram tablets, I think Hetero has made it much more easier. 2 tablets of favipiravir 800 mg plus 1 tablet of favipiravir 200 mg in the morning, and 2 tablets of favipiravir 800 mg plus 1 tablet of favipiravir 200 milligram in the evening. So that will mount up to 3600 on day 1, followed by 800 milligram BD. That is 1600 milligram per day from day 2 to day 7. If the patient is slightly symptomatic and yet is in the mild to moderate category, you can extend the dosage up to 10 days as well. So I hope the dosage is clear. 800 milligram favipiravir tablets, 2 tablets in the morning, plus 200 milligram 1 tablet. So it is a strip which is available, which is much more easier for the patients to understand and consume the tablets. From day 2 to day 7, it is 1600 milligram on a daily basis. That is 800 milligram in the morning and 800 milligram in the evening. So where are the patients? I mean, what are the patients whom we have to be cautious enough? So pregnant women, I have not used personally. Lactating mother also we have avoided. Patient with gout and history of gout. Okay, this is a moderately, I would like to say relative contraindication. If the uric acid is okay, if you are able to monitor the uric acid, if the patient is not in an acute attack of gout, you can still use the favipiravir tablets. Children, it is not very, I have not used personally. Geriatric patients, I think this is something which we have used very commonly. Earlier, it was advised to be cautious in geriatric patients, but we have carefully, we have freely used the favipiravir in geriatric patients as well, provided we have got a facility to monitor them. Maybe we can repeat a liver function test maybe after 3 days. If there is no transaminitis after 3 days of tablets, usually they will not develop any kind of complications like transaminitis or liver dysfunction. So they are safe in geriatric population. You can use them without any hesitation. Renal impairment and hepatic impairment, you should be using with caution as well. So drug interactions, we are hardly using any of them for the drug interaction. So I will not go much into the details of it. If at all there is a pyrazinamide, there could be an increase in the uric acid levels. We should be able to monitor that. This repaglinide, theophylline, famiciclovir, sulindac, and all we are rarely used. So we need not go deeper into the drug interactions of favipiravir. Overall, to say favipiravir is a relatively safe drug which can be used on a OPD basis, which can be used in all, adolescents to geriatric patients. Pregnant and lactating women, avoid them. And even in children less than maybe 10 to 12 years, it is better to avoid it. What are the benefits of starting antiviral early? Early initiation, as I told you, within 72 hours helps to overcome the disease progression, offers faster viral clearance within 4 days and symptomatic relief within 7 days, reduces chances of hospitalization and reduces overall treatment cost. And most importantly, it limits the future complications of post-COVID-19 recovery. So earlier we diagnose, earlier we start the treatment, earlier we earlier we facilitate the patient to recover, the better will be the outcomes. That is the greater benefit of starting antiviral early in the course of the disease. Coming to post-COVID-19 complications, this is just a single slide. I would like to highlight pulmonary fibrosis. It is seen, but not very commonly seen. The patients are showing recovery. Patients whom we thought are having fibrosis permanently are showing increase in their oxygen levels. The CT scan is slightly becoming, slightly improving. So we have not repeated very oftenly. We are monitoring most of them on a saturation basis only. They are able, their exercise capacity has increased. They are doing, they are able to carry their oxygen requirement has come down. So these are very, very encouraging results. But still, pulmonary fibrosis is a very well-known complication of post-COVID-19 infection. Cardiovascular complications like myocarditis, myocardial infarction, these are all known. Diabetes, I want to say, a possibility. A blood pressure is again a possibility. DVT, as you all know, it is a prothrombotic disease. So it is very, very important for all of us to be vigilant and be very cautious in identifying thrombotic diseases in these patients. So better to put them on anticoagulation for maybe a month or so, 1 month to 3 months. Again, some people we are continuing them for 3 months when who had initial higher D dimer or their D dimer continues to be higher during follow-up, and people whose D dimer has returned back to normal. I think we have stopped at the end of 1 month. Blurred vision, I think this again was a newspaper report where I saw that there is a possibility of central retinal vein occlusion. Because of this, the patient had developed blindness or blurred vision. That again was a thrombotic complication of COVID-19. This is just a small slide on the possible complications. So this is the complications are again out of the scope of this particular discussion. So I have limited it to only one single slide. So with this, I would like to end my presentation. So if you got any questions or any doubts, we will be happy to answer. Kapil, you have got anything to share?
Yeah, I think Dr. Sandeep has covered it very beautifully and eloquently. In fact, it has been a very brief and actually thorough presentation, right from diagnosis to the possible treatment, and then probably how to treat and how to treat empirically. I think the key word is basically empirical, as he has rightly pointed out. Everything is COVID in this pandemic, unless so you have to rule out COVID rather than ruling in, because everyone is ruled in as an COVID. So probably your task is very easy as a general practitioner or as a pulmonologist, where you know everything is COVID. Now you have to prove that it is not a COVID, so it becomes more easier for us. So once it becomes easier for us, probably we'll use more drug. And because now we are almost 9 to 10 months into pandemic, and we have used favipiravir for so many patients, now we are more confident about this drug. Probably we have seen much better result with this drug. Probably we have saved more life with favipiravir as compared to what we used to be in March, April, or May. It was approved in June. So after June, I think mortality has come down. Probably me and Sandeep will both will agree to this point, that we have saved more life, more patient have been, we have benefited more of our patient for not going on ventilators or an NIV or a non-invasive ventilator. Probably a home isolation and quarantine was more than enough in addition to favipiravir. So I think all in all, it's a wonderful drug. Probably I am not saying it's a game changer, but at least it's a lifesaver and a drug which can be used very easily. Previously we used to talk it's a too toxic, but we all know after using for more than 500 plus patient, we know it's a very simple drug to use now with 800 milligram available. Probably hardly two tablets. Your diabetes tablets are more than your antiviral tablets now. So probably a simple 2-3 tablets per day for 7 to 10 days without any side effect, or very probably very few side effect, you can manage this patient. And as he has rightly pointed out, once you manage this patient in mild disease, you prevent this patient from going to mild to moderate. Probably you are preventing a lot of post COVID complication what we are seeing now, or probably we will be seeing another 2-3 years. So I think in and all, so it will not only cut down on mortality but also the morbidity part also. So these are the two important messages what Dr. Sandeep has tried to give. He has covered it very beautifully. We will be more than happy to answer your questions. Thank you very much.
There are no questions in the chat box, I think.
Ital, are there any questions?
No, sir. There are no questions as of now.
No questions?
No, sir. Sir, any specific cases that you would highlight where the use of favipiravir has really helped, so which can help in the for the benefit of the group, sir?
Yeah, I think one thing I just want to point out, maybe Dr. Sandeep will add to this, like, very important to understand, the epidemiology of the disease. Once you get a patient who is positive for COVID-19 in a family of say 8 or 10, guys at one home, if someone get positive by RT-PCR or whatever means you are taking, and then you start favipiravir in this patient, but then suddenly, if second day, third day, someone comes, with some same symptoms and everything, as Dr. Sandeep has rightly pointed out, don't wait. He's a pakka COVID case. So you have to start favipiravir before actually give him he actually go for a maybe a sample of maybe swab or CT or something. So this is how you will prevent the disease progress, and that is very important, because as you have rightly pointed out, it has to be started within 72 hours. In fact, I'll recommend it much more aggressive. What we have done in that Mumbai study was, it was within 48 hours. Probably, if possible, within 24 hours, if you can start, if that 3600 milligram goes in first 24 hours, probably your symptom, or what your clearance of the virus or viral load or the infectivity will come down by 3 to 4 days as early as possible. So probably within a weeks, within 1 week you will make patient swab negative. That means he is non-infected. That means he can go early to the community, he can be a non-spreader, plus he can save a lot of money for hospitalization, he can save a lot of bed for sicker patient, plus he can be available for his routine activity as early as possible, versus a patient who's not started on 5-piravir, which might take 10 to 14 days as a body response. So that is very important. So I think little bit of common sense, a little bit of vigilance, that is how it should be used. So nowadays we are very aggressive in treating patients with 5-piravir. The patient movement little symptomatic and we are suspecting, or where we know there is an index care at home, probably I'll be more aggressive in treating other patients also at the home, rather than actually waiting for maybe a CT or maybe a swab, anything. I don't know. Dr. Sandeep, your views on this?
Absolutely, totally agree with you. There is no doubt about it. I think we should be very vigilant. We should be very cautious. We should be proactive. See, I think ultimately patients will not know. I think we have to, as a doctors, as a treating physicians, we have to be much more, proactively identifying the cases, starting them on proper treatment and trying to save the life. See, most of the patients will be in a denial mode. I think, no, COVID, oh, kaise humko ho sakta hai? How can it be, I get infected with COVID and all this stuff. I think we should be, we have understood the fact, at least as a specialist, I think we have understood the fact that any case coming to me is a COVID, unless otherwise proved. So I would like to investigate him accordingly if needed, or start them on broad spectrum antiviral and then wait for the response. So that is what we follow. I think I totally agree with Kapil in this matter.
Yeah. Anything more, Sheetal? Anything is there?
No, sir. That I guess that is also. So yeah, sir. So, sir, there are no questions. So I guess the whatever discussion we had, the participants were quite have understood the entire the disease profile, as well as the investigations that need to be done, and how favipiravir early initiation will definitely help to curb the symptoms and give better relief to the patients. So on behalf of Hetero Healthcare, sir, I thank all the delegates who has joined us today. And I'm sure that the clinical insights shared by Dr. Sandeepa and Dr. Rathi has surely helped them and given them the confidence to manage the COVID-19 patients effectively. And I thank Dr. Sandeepa and Dr. Rathi to give their valuable time and share their clinical insights. Thank you very much once again on behalf of Hetero Healthcare. Thank you, sir.
Thank you, Shidhar. Thank you.
Thank you,
Thanks,
Sheetal.
Kapil.
Pleasure. Thank you, Sandeepa. See you again. Catch you again. Stay safe. Stay